Welcome to this film, which is about renal transplantation in Leeds. You'll meet a number of members of the team during this film. I'll tell you about various aspects of transplantation. The renal transplant programme in Leeds is busy and we do about 200 transplants a year. During this film we'll talk to you about some of the advantages of having a renal transplant and also some of the complications that occur. Having a successful renal transplant gives you a number of benefits in your life. Perhaps the most obvious one is that you no longer need to do dialysis, and that gives you back a lot of time and freedom. It's also beneficial to your family and friends, and you'll be able to spend more time enjoying your hobbies and pastimes. There's good evidence that having a successful transplant will make your mood better and reduce episodes of depression and anxiety, but perhaps most important, will give you more energy and allow you to do more things and improve your physical performance. There's also good evidence that having a successful transplant will actually increase your lifespan, mainly by reducing the risks of cardiovascular disease like heart attacks and strokes once you have a successful transplant. Despite all these advantages though, there are some complications that can occur after transplantation, and during the film we'll make you aware of some of these as well.
Hello, my name's Dr. Hamish McClure. I'm one of the anaesthetic consultants here at St James's Hospital, and I'm one of the anaesthetists that will be looking after you when you have your kidney transplant. Once you've been listed for a kidney transplant, there are some things that you can do that will really help your outcomes. The first thing is to get as fit as you possibly can. A lot of the patients who come for a kidney transplant haven't spent much time exercising, but exercise and being physically fit will really help. The second thing is to try and stop smoking. Patients who smoke often get chest infections and can suffer from significant complications after the operation. So if you can stop smoking, that would be really useful. And thirdly, if patients are a little overweight, it's really useful if they could lose some weight, and that'll improve their complications as well.
Before you're activated on the transplant register, we also ask for you to be up to date with any routine cancer screening, such as mammograms and bowel cancer screening. Whilst you're waiting for a transplant, we need to know if you're admitted to hospital, as this may have some bearing on whether or not it is safe for you to remain active on the transplant register. If you're admitted to hospital, please can either yourself or one of your family members notify your local transplant team. Whilst you're waiting for a transplant, you may wish to go on holiday. If you're leaving the mainland UK, then we need to suspend you from the transplant register, as we are unlikely to be able to get you back to Leeds in time for a transplant.
If you are holidaying abroad, depending on the location and if you're going to need any dialysis, you may require a period of suspension of up to 3 months. Please contact your transplant team to discuss further. If
you are planning on holidaying on the mainland UK, then we ask that you contact your local transplant team before you go on holiday to discuss whether it is best in your circumstances to remain active on the transplant register or to be suspended while you are away. If you choose to remain active, then we need to know where you are to allow additional travel time. You'll be expected to make your own way to Leeds. We strongly advise for you to have a dental review before you are activated on the transplant register and a yearly checkup thereafter. This is to ensure that there aren't any infections in your mouth which could become worse and spread after a transplant due to the anti-rejection medications.
The role of the renal dietitian is to find out about your lifestyle and your usual way of eating and drinking. We can then work with you if you need to make any diet changes to help keep you well. Nearly everyone with a kidney condition will be encouraged to reduce the amount of salt in their diet. Part of keeping well while you're waiting for a kidney transplant involves being a healthy weight, and your transplant coordinator will discuss a target weight with you. If you have been advised to lose some weight, or you have already lost the weight and want to make sure you don't put it back on, there are a few options available to you. You could join a weight management group such as Slimming World or Weight Watchers, which is near to you, as many people find attending weekly meetings really helpful, as it helps them to keep a check on their weight and helps keep them on track. Once you have reached your target weight, it is important that you maintain it. Unfortunately, if you gain weight, you may be suspended from the transplant register until you have reached your target weight again. On the other hand, for people who have been encouraged not to lose any more weight but are struggling to eat well, you could ask to speak to one of the renal dietitians, as they may be able to support you in how to enrich your diet.
If you have put on significant amount of weight since your last review when you come to hospital for a transplant, then it may be decided that the operation has become too risky and it may not go ahead. It is really important that you try to lose weight if this has been advised.
If you get coronavirus whilst you're waiting for a kidney transplant, please contact someone from the transplant team. You'll be temporarily suspended from the kidney transplant register. This is to make sure we do not harm you by transplanting you whilst you have coronavirus. After a positive coronavirus test, you will need to be suspended for 4 weeks, even if you don't have any symptoms.
Antibodies are small proteins produced by your immune system that circulate in your blood. These antibodies may attack donor HLAs and potentially damage a transplanted kidney. You may have HLA antibodies if you have ever had a previous transplant, if you have ever had a blood transfusion, or if you've ever been pregnant. Occasionally, your transplant coordinator will give you a questionnaire to fill in that asks if you've ever had any transfusions or infections. It is important to fill these questionnaires in and let your transplant coordinator know if you have had a blood transfusion recently. HLA antibodies can appear, disappear and reappear over time, so it is important that we do this test regularly. If you are waiting for a transplant, we must do this test a minimum of once every 3 months to ensure that any transplant offers that you get will be compatible and safe. This is a blood test that is normally sent by your dialysis unit or by the patient clinic.
So once you're placed on the renal transplant waiting list here in Leeds, you're seen in our annual consent clinic on about a yearly basis. And this is for us to check that there's been no significant changes to your medical condition since you were last seen, and that you're suitable to remain on the transplant waiting list. And the second reason for seeing you is to run through the details of the procedure, the risks and benefits in particular, and to get you to sign the consent form. Occasionally we need to either suspend people temporarily or even remove them from the renal transplant waiting list. If we have to suspend you, it's usually temporary, and that may be due to an illness such as a chest infection that you've developed. That means it's not safe to transplant you at that time, but that once you've recovered from that infection, you can go back on the waiting list. Unfortunately, sometimes people become more unwell, develop other medical conditions whilst they're on the waiting list. That means that you're not suitable to stay on the waiting list and no longer able to have a transplant. And unfortunately, in that situation, we do have to remove you from the list. That's not a decision that we take lightly, and that would of course be discussed with you. Fortunately, it's actually a rare occurrence, and the vast majority of the people who are on the transplant waiting list do get a kidney transplant. I'd like to talk a little bit now about the different types of donors that we get kidneys from. Broadly speaking, these can be divided into deceased donors, those who have passed away, and living donors. In terms of deceased donors, this can be divided further into 2 types. Firstly, donation after brain death donors, which is abbreviated to DBD, and these are patients who've usually had some sort of catastrophic event in their brain, the most common being a bleed, and that means that they are brain dead. In this situation, because they're brain dead, we can go in and remove the kidneys whilst the heart is still beating. And that means that there's no time where the kidneys are not getting blood before we flush them out. The second type of deceased donor is called donation after cardiac death, or DCD. Now here they have usually also had something very serious going on within their brain, but they don't meet the criteria to be brain dead. In that situation, we need to wait for the heart to stop beating before we're able to take the kidneys out. And so there is a period of time where the kidneys are not getting oxygenated blood, and are warm within the body. Now, in the long term, this doesn't actually have any effect on the results of kidney transplants. However, we do know that this period for donation after cardiac death kidneys, where they haven't had a blood supply, does mean that they are less likely to work straight away. We call that delayed graft function, or also the kidney going to sleep. And we know that kidneys from donation after cardiac death, or DCD donors, are about twice as likely to not work straight away. However, as I said, in the long term, they work just as well as kidneys from brain dead donors. If we compare the results of kidneys from deceased donor with those from live donors, we know that roughly 98% of kidneys from live donors are working at 1 year, compared to about 93% of kidneys from people who've passed away at 1 year. If you then look at 5 years after transplant, we know that the difference between the results reduces slightly, so about 89%, or 89 out of 100 kidneys from live donors will still be working at 5 years, and about 87%, or 87 out of 100 from deceased donors will still be working at 5 years. Here in Leeds, something that we've specialised in over about the last 10 years is transplants from small children and babies. Below the age of about 5 years, we have concern that putting one kidney in would not provide good enough kidney function to keep people well after transplant, and therefore usually for kidneys from donors less than 5 years of age, we do what we call an en-bloc transplant. Here we take both kidneys with the main blood vessels that join them together and plumb them in together.
When we get an offer of a kidney transplant, then obviously that organ will have come from someone who has passed away and has agreed to donate their organs. What that means is that the kidney we get has already lived a life in someone else, and that can mean that there are other diseases and illnesses that they may have had during life which can affect the quality of the kidney that's being offered up for donation. One of the things we will do is carefully look over all of that information and make sure that we think that this kidney is suitable for transplantation. That does mean, however, that there are illnesses and diseases which the person may have had which can contribute to the quality of the kidney and can sometimes mean that it doesn't work as well as we would like. And we have to perform a risk assessment of the quality of that kidney versus not doing a transplant in the recipient, who will undoubtedly have problems of their own whilst they remain on dialysis. Some of the things that we may encounter when patients donate their organs are things like high blood pressure, diabetes, being overweight, and other medical conditions that can affect the quality of the kidney. One of the main things that we know that can affect the quality of the kidney is donor age. And we are seeing, as time goes by, donors being offered for transplantation who are becoming older and older. And that's okay. We can assess the quality of these organs by a variety of different measures, but occasionally if a donor is in their 70s or above, we may elect to use both organs and do a dual transplant, which is a bigger operation, and it would mean that you would have both kidneys transplanted instead of just one. But again, all of these factors are taken into account at the time and will be discussed with you fully before we proceed to transplantation.
Are live donors, and now these are commonly loved ones, so mother, father, brother, sister, for example, of the recipient. Can also be a friend or a less close relative. Now, these are really the gold standard of kidney transplants. That's because they're coming from a fit and healthy person who has to go through a very vigorous set of tests to make sure that their kidneys are healthy. And also the kidney is on ice for a very short period of time between coming out of the donor and going into the recipient. And for that reason, kidneys from live donors work the best out of all types of transplant.
The key thing really is no waiting time on the national waiting list. Depending on your ethnicity and blood group, you may end up waiting a fairly long time. So having somebody coming forward to donate a kidney means you don't have to wait. Have kidney transplant in a planned way, so you could plan your life around it. It is also evident from national data that people who receive a living kidney donation have a better life expectancy, and the kidney works longer than actually having a kidney from a deceased person. There is no set age barrier. What they need to show and prove is they are fit enough to undergo an operation, but also that they are not at risk of any disease for future. Living kidney donors live a very healthy life with good quality of life. There are certain fear and perception which varies between communities. So for example, one of the important aspects for South Asian community is about a young lady or a woman whether they could donate a kidney. And the fear and anxieties around ability to become pregnant after donating a kidney. So in general, we advise that a pregnancy after live kidney donation is safe. It is important to emphasize that after living kidney donation, whether it's a man or woman, their working ability is not affected. After a recovery of 6 weeks, they are very normal. Their physical ability in both work and for the sports is not affected. If anything, they feel much more positive after helping their loved ones.
For information from your local centres, please contact them to move forward as a live renal donor. Here in Leeds, if you'd like to contact the renal team, they will be able to take some basic medical information from you and then be able to move you forward to look at some information online and to get a health questionnaire for you to be sent back to us. This is a unique situation with an operation that you do not require for your own health benefits. Therefore, at any point, you can stop this process. If you are not compatible with your recipient, there is a process called the kidney sharing scheme. This is a scheme where live donors who are not compatible with their recipients are put into a pool 4 times a year, and they are matched with other donors and recipients in other centres. The benefits of this are that the recipient still receives a kidney from a live donor.
There can be occasions where patients may want to request on Facebook that people come forward to be potential donors for them. We would ask you to discuss this with your transplant team in advance of making such an appeal.
Hello, my name's Tina Suryavansi. In January 2003, I became my son's first living-related kidney donor. I had my fears at the time. I was scared about the pain, I was scared about how long I would be off work. Looking back on it now, it was the best thing that I could ever did for him. It changed his life, it's given him a healthy life. He's been able to go back to school, get himself an education, his diet changed, he's developed fine. I can honestly say it was the best decision I made. I myself have lived a completely normal life.
Occasionally, you might get offered a live donor kidney from what we call an altruistic donor. So this is someone who's come forward and asked to donate their kidney to someone that they don't know as a gift. And what happens then is that the best match around the country for that altruistic donor is found from the waiting list.
The allocation scheme ensures that there is a good tissue match for the kidney, but also a good age match for the kidney based on how long the transplant needs to function for. There are 2 groups of patients within the national allocation system, Group A and Group B. Group A is the much smaller group, and that exists for patients who have been waiting a long time for the transplant, over 7 years, and also who have a very difficult to match tissue type. Group B patients, the majority of patients fall into this category, and within this group you're given a score, And that's based on numerous factors, including your age, the number of days you've been on dialysis for, your blood group and your tissue type. When a kidney becomes available for transplantation, that kidney is then matched against everybody in the national allocation system. The person with the highest number of points will be offered that kidney as long as the transplant team are happy.
Your tissue type is also known as your HLA type. It's tested by the lab before you become active on the register. HLA are markers found on most cells of your body. Your immune system uses these markers to recognise which cells belong to you and which do not. If these markers are different to the donors, your immune system may recognise the difference and attack the transplanted kidney. When a kidney is available for transplant, we will test to see if the kidney is compatible with you by mixing your blood with the donor's cells. This is called a cross-match, and it usually takes about 4 hours from when the kidney arrives at St James's. When the result is ready, the transplant team can then make a decision about whether or not the donor is suitable for you. A compatible result means you have no antibodies against your donor. But if you have antibodies against your donor, this may mean an incompatible result. In some cases, we don't have to perform a cross-match, so we can reduce the amount of time the kidney is without blood before being transplanted into a recipient, which may increase the long-term success of the transplant.
There are two areas that we really look at very carefully in donors when it comes to transplantation. And the first of those is donors that may have a risk of a malignancy themselves, either one that we know about from the past or one that we don't know about but that we encounter at the time of the donor operation. All donors are carefully examined from an external point of view and at the time during their donor operation to try and exclude any possibility of transplanting an organ that has a cancer in it. Whilst this is very successful, there are very occasionally malignancies that are missed, and this does pose a small risk of being transmitted from the donor into the recipient. This is the case for all organs that are transplanted, and although this risk is very small, it is never absolutely zero. The other thing that we would mention to you is there are viral illnesses that can sometimes be transplanted as well. These are things like hepatitis B, hepatitis C, or HIV. And all the donors that we use are screened for these viruses to make sure they're negative before transplantation. That being said, there is always a small window period between the donor potentially contracting that and it being detectable. And if we happen to have a donor within that window period, there's a very small chance that that could be transmitted on to you. Although again, the chances of that are very small.
Human herpes virus type 8 is one of the family of herpes viruses. And in that way, it's a similar infection to things like chickenpox, shingles and cold sores. Although in the United Kingdom, human herpes virus 8 is actually less common. NHSBT, who run the transplant programs in the United Kingdom, have been screening all donors to see whether they carry this infection. The infection rate is approximately 5% of all donors in this country. We know that human herpes virus 8 can be responsible for serious infections, but of the samples, only a very small number of infections have occurred into people who've received organs from donors who are HHV8 positive. This has resulted in only a handful of infection-related illnesses. If the donor of your organ is found to be positive, which will be likely in about 1 in 20 cases, about 5%, then we will initiate a screening program after your transplant. This will involve regular monthly testing for the first 6 months and then less frequently up until 18 months after transplant. It should be emphasised that the chances of transmission of the infection, even in a donor who's positive, is very low indeed. If you do become positive, then it will allow us to possibly make changes to your medication and to track you very closely so that we can keep an eye on you and watch out for any potential problems.
There is a varying degree of risk associated with deceased kidney donors. Some kidney donors may have more risk than others. Factors such as previous intravenous drug use will be discussed with you prior to the transplant going ahead and explained in as much detail as the information that we have available allows. If you are not comfortable with what you are told, then you can decline the kidney. This would not affect you receiving future transplant offers. There is a national fast-track screen in the UK. This is where kidneys are allocated to all of the participating centres at the same time in order to place the kidney as soon as possible. If your kidney has been offered via the fast-track system, then this will be explained to you prior to the transplant taking place. There are a wide variety of reasons why a kidney may be offered for transplant via the fast-track system. Some of the more common reasons are if the original intended recipient is unwell when they come into the hospital for a transplant, or the kidney wasn't thought to be suitable for the people on the transplant register who it was most closely matched with.
There is a small risk that coronavirus could be transmitted to a patient with the transplanted organ they are receiving. This is extremely unlikely. Nonetheless, we carefully consider this risk when an organ is offered to us for one of our patients and always seek to keep this risk low, but we cannot reduce the risk to zero. In some circumstances, we may consider using a kidney from someone who has a positive coronavirus test. It is possible for a donor to have a positive coronavirus test and not be infectious, and our increasing understanding of coronavirus means we may sometimes consider using a kidney from a donor like this. We would only ever do this with the specific consent of the person receiving the kidney. We will discuss this with you openly if it is ever relevant to a kidney you might be able to receive.
The call for renal transplant can happen anytime, day or night, weekend and evening times. So it's very important that all your contact numbers are up to date and that we know if there's been any changes. When the transplant coordinator contacts you with a potential offer for a kidney transplant, we will tell you whether you need to fast or whether you can eat before you come in. The current protocols for renal transplant are that you are to fast 6 hours before surgery and you can have clear fluids up to 2 hours. The staff on the ward will let you know when you need to be nil by mouth. You should also think about a plan for dependents should you be called in for transplant, whether these be children, people that you care for or pets, as this call may come in the middle of the night and it is good to have a plan in place. When we call you in for renal transplant, we will need you to bring with you an overnight bag. Inside this you should have some pyjamas, some loose fitting clothes for when you go home, your medications and any toiletries. If you're in a rush and unable to bring any of those with you, don't panic. We have supplies on the ward and your relatives can bring this at the next day. We do have a 2-hour time limit in which to contact you for renal transplant. If we are unable to contact you during this time, then we will unfortunately have to move on to another recipient. So again, it's very important that all your contact details are up to date.
Please make a plan of how you will get to St James's Hospital when you receive the call to come in for a transplant, bearing in mind that this could be any time of day or night. We strongly advise you not to drive yourself in, but if you do not have anyone available, then we can send a taxi for you. Any accompanying relatives would need to make their own way home.
J49 is our male renal unit and J50 is our female renal unit, both located on the first floor of Lincoln Wing. You are likely to be admitted and spend the duration of your stay in one of these ward areas.
Occasionally, the bed may not be ready on arrival and you may have to sit and wait outside of the ward while this is made for you.
When you come in for a kidney transplant, you'll be seen by the anaesthetist. They'll want to have a discussion with you about your general condition and check and see whether anything has changed since you were last seen and reviewed in clinic. They'll ask you a little bit about any symptoms that you might get from your heart, any symptoms that you might get from your lungs, and they'll want to know what drugs you're on and whether you have any allergies. They'll also want to know what happened with any anaesthetics that you've had in the past. They'll then want to look at any new investigations that have been done. We'll have performed a chest x-ray and a heart tracing, and we'll need to check and see that there are no new abnormalities on either of those tests. In a small number of patients, their kidney function isn't quite good enough to have anaesthesia and surgery. So in those situations, those patients will receive a short period of dialysis before they come to theatre.
Hospital policy dictates that we have to perform a pregnancy test on females under the age of 55 years before an operation.
Once the donor kidney arrives at the hospital, it's important for the consultant transplant surgeon to look at the kidney and examine it carefully before making a final decision about whether or not to proceed. Very occasionally, once the kidney arrives at the hospital, we uncover something that means that it's not suitable to be used. This can range from damage to the organ that hasn't been realised at the time of the retrieval operation, or it can be an unexpected finding such as a tumour in the kidney. We will look at these things very carefully and we'll come and discuss them with you if there's any concerns. But it does mean that very occasionally, even up to the last minute, you can be turned down for an organ transplant on the day because we find something that we don't expect. Sometimes as part of the transplant process, a biopsy is taken of the kidneys that are going to be used for transplant, and we do this for really one of two reasons. The first reason is sometimes to make a decision about the quality of the kidney that we're going to transplant into you and decide if it's going to be suitable or not. The other time we take the biopsy is called a quad biopsy, and that is a research study to look at the quality of organs, and that tissue would go into storage to then be looked at a later date for research purposes, as there is a small risk of bleeding if we biopsy the kidney before it's transplanted.
Kidneys are transported in special perfusion fluid. A sample of this fluid is sent for testing on arrival for any sign of infection. The results are normally available after a few days and any treatment started if required.
The kidney transplant operation itself takes around 3 hours. Obviously, it can be quicker than that if things are straightforward, or longer if particularly you're having a dual transplant or you've had previous transplants. After the operation, it takes time for you to wake up fully. So usually you'll be up in the theatre complex for about 6 hours for your transplant operation. It's very important to us that you have good pain relief available after your transplant operation, and there's a number of different things that we do to help with that. At the time of the operation, we inject local anaesthetic into the skin and muscles, which works for about 12 to 18 hours after the operation. You'll also have what we call a PCAS, which is Patient Controlled Analgesia System. That's a button that we give you that when you press it, it gives you a small dose of strong pain relief, which is a morphine type drug. Now the advantage of that is that's available when you need it, so you press it whenever you feel uncomfortable. You can't overdose on it. There's a preset system that doesn't allow you to overdose. On top of that, you can also have additional painkillers from the nurses as required. Usually we remove the button on the day after surgery, and following that you'll be given tablets to control your pain.
In rare occasions, some patients need a little more looking after the operation, after they've had their kidney transplant. And in those circumstances, we'll arrange for a bed to be made available on the critical care unit, where they can be more closely monitored by one of our nursing staff.
Very rarely, when we transplant a kidney, even although the blood supply is good and there's no obvious reason for it, it never works. We have a rate of about 1% in this centre, and that is in keeping with the rest of the country. This is called primary non-function and means that the kidney will never work, will never produce urine, and you would not get off dialysis by having this transplant. One of the most significant surgical complications that you can have as a result of your kidney transplant is a clot developing in either the artery of the transplanted kidney or in the vein of the transplanted kidney. What happens if this occurs is that the flow of blood around the kidney stops, and it means that the kidney will then not survive and will have to be removed as a second operation as an emergency. Obviously this means you will not then be off dialysis at the end of this procedure, and you will have had 2 surgeries and still remain on dialysis. This is a rare complication, thankfully, but it does again happen a couple of times a year in most centres, and ours is no different. It's very upsetting for the recipient when this happens, but it is important that we remove the kidney, otherwise you would become very unwell. One of the things we try and do, wherever we can, is transplant someone just before they start dialysis, because this minimises the time that they're on hemodialysis, which means that they're less likely to face the complications that that can bring, and it means they then have a transplant that's going to last them the longest possible period of time. The only thing to mention about that is if you're not yet on dialysis and you have a transplant that doesn't work and then has to be removed, stress and trauma of having 2 operations in close proximity to one another can occasionally mean that someone who wasn't on dialysis before they came into hospital can end up needing to be on dialysis, as that stress can put a strain on the kidneys and push you into the requirement for dialysis afterwards. Thankfully we see this very rarely, but it can occasionally happen.
All patients after a kidney transplant will have a catheter, which is a small tube that goes into the bladder and drains the urine. This is to allow us to keep a very accurate measure of how much urine you're producing after the kidney transplant, but also to reduce the pressure on the bladder and on the new join between the bladder and the kidney. Usually this is removed after 5 days. Also used to protect the join between the kidney and your bladder is what we call a stent. This is a very thin plastic tube, similar to the inside of a biro, and it runs from the kidney into your bladder. The idea of that is it keeps the join open and allows the urine to drain freely. That's usually removed at 6 weeks after the transplant operation, and that's as a day case procedure under local anaesthetic, where a very small camera is passed into the bladder and the stent is grasped and pulled out.
As part of the transplant operation, we have to join the tube that drains urine out of your kidney onto your own bladder. And in doing so, occasionally urine can leak from that join into the abdominal cavity. This is a rare complication. However, when it does happen, it's relatively easy to fix, but it may require a second operation to put things right. Usually, however, it would not result in any long-term damage to the kidney. Another complication that can happen as a result of joining the ureter onto the bladder is that the end of the ureter can become narrowed, and this is called a urinary stricture. This is an uncommon complication, however, it can be troublesome to put right and can require multiple stents to be placed over a long period of time, or occasionally, if it doesn't get better, we have to do a second operation to reimplant the ureter, which can mean coming into hospital again for further surgery.
Occasionally, you may also have a drain, which is a plastic tube which comes out of the skin close to where the transplant wound is. We don't use these in all our transplant operations, so this won't necessarily be the case. The idea of the drain is to let any fluid out and prevent it collecting around the kidney. And usually that's removed on the ward 2 or 3 days after the operation. Everybody loses a little bit of blood during a kidney transplant operation because we are operating on blood vessels. But in the vast majority of people, that's not enough blood to need a blood transfusion. Only between 5 and 10% of our patients need a blood transfusion, and that can either be during or after the operation. Less commonly, people can get bleeding after the operation. It's usually in the first day or so. Often that doesn't need anything particular done about it, but very occasionally people do need to be taken back to theatre if there's bleeding that's carrying on and not going to stop on its own. And the chance of that is about 1 out of 200 transplant operations that we do.
During your transplant operation, the dissection that takes place, which obviously involves the blood vessels, can also sometimes disrupt small channels which are called lymphatic vessels. These are tiny and have a clear fluid, and sometimes after the operation they can continue to leak. Usually this doesn't cause any major problems as long as it's minor, but very occasionally they can leak for a long period of time, and this will result in a build-up of fluid around the transplant called a lymphocele. Normally this can be managed just by examining you and looking at ultrasound scans to see that it's not increasing in size, but very occasionally it can put pressure on the kidney, which means you have to have either a drainage procedure done or very occasionally a second operation to drain the fluid into your abdominal cavity. One of the things that can happen during the transplant operation is that some of the nerves that supply the skin can be damaged, and this normally results in a patch of numbness either across the wound itself, or very occasionally, if it's some of the deeper nerves, it can result in a patch of numbness on the inner thigh. However, none of the nerves that are involved would supply your motor function, therefore your movement shouldn't be affected. Normally this recovers over time, but occasionally people are left with a degree of numbness in the long term, but it really causes much trouble. Following your transplant, you will then go back to the ward. One of the things we look out for very carefully after your transplant is the possibility of you developing an infection. The reason why that's so important is that after your transplant, you will have a lot of immunosuppression medication on board, which means you're less able to fight off an infection should you acquire one. The sorts of infections that you're susceptible to are things like chest infections, infections in the wound, and infections in the urine. And we will give you antibiotics if there's any suggestion that you're developing any of these. You will also receive some antibiotics at the time of your surgery to reduce the risk of you contracting one of these infections. Don't worry if it happens, it is quite common, and we're well accustomed to dealing with it, and we'll make sure we give you the right antibiotics to get you over the infection. One of the infections that we hear a lot about in the news is MRSA. It is something that happens to be in most of the hospitals in the UK in one place or another. We will screen you for this when you come in, and it doesn't necessarily mean that you will have any problems with that, but it's something that we do alert you to, because if you do have an MRSA infection and you're immunosuppressed, obviously that can be problematic. However, we see very, very low incidences of that in our transplant patients. One of the other things that can happen after your transplant operation is that you can develop blood clots either in the leg, or even more severely, they can end up travelling into your lung. This is called a deep venous thrombosis, or if it moves into the lung, a pulmonary embolism. These can be very serious complications as a result of your transplant operation and can pose a risk to your health and occasionally even your life. As a result, we will give you some stockings to wear when you come in to reduce the risk of that, and you will also be given an injection of heparin every day whilst you're in hospital to keep the blood slightly thinner than usual and reduce the risk of you developing a clot in either your leg or your lung. These prophylactic measures are very successful, and therefore we see a very, very low rate of these complications happening in our transplant population. Following your transplant operation, we would expect most people to make a good recovery and to live the rest of their lives out without having to be on dialysis. The transplant operation is a big operation, however, and with that comes a risk that people will not survive it. That risk in transplantation is very low, and the number we would normally quote people is around 1% mortality risk, which means there's a 99% chance that you will survive the surgery and go home.
ERAS is focused on improving your recovery after transplant. We know that patients who are able to mobilise soon on after transplant are less likely to develop complications such as chest infections and blood clots. We will also provide you with an ERAS calendar. We know that patients who are able to follow this are more likely to go home sooner. You will be provided with a diary to fill out on the ward after your surgery. It contains a calendar about what we expect from you each day after your operation. As early as 6 hours after returning to the ward, we'll ask you to sit out of bed for a short period. You will then build up to walking around the ward and following a signposted ERAS lap. You will also be provided with a spirometer to help you with breathing exercises. This will reduce complications such as chest infections. We advise you to bring chewing gum with you after the operation. This will help with complications such as constipation. We also ask that you complete a fluid diary after the surgery. This will monitor how much fluid you're intaking and how much urine you're passing. ERAS is all about your independence after your transplant. We ask that you try and gain your independence soon on after surgery, and as early as 4 days on, we expect you to be showering independently. This may sound like a lot of work, but ERAS is about taking ownership of your care and reducing complications and making sure you go home soon after your surgery.
Following your kidney transplant, we would expect you to be in hospital for about 7 to 10 days. If the kidney doesn't function immediately, we would anticipate that your stay would be longer, usually about 2 to 3 weeks, but you would continue to recover and feel better during that time. We would expect you to feel much better after your transplant surgery after about 6 weeks, but to return to heavy duty work, lifting, very physical housework, we would expect you to feel capable of doing that within about 12 weeks after your surgery. We don't encourage you to do heavy lifting or very manual work before that time, as you're likely to find it quite uncomfortable.
Following the transplant operation, the wound will heal up. However, occasionally patients may develop a hernia following the surgery. This is where part of the abdominal wall underneath the skin gives way and results in a bulge to the side of the abdomen. Sometimes this can be uncomfortable, and we can do a further operation to repair the hernia if required. Whilst this is an unpleasant side effect, it is actually quite uncommon, and most of our patients don't have this complication.
Transplant patients are classed as clinically extremely vulnerable in relation to coronavirus risk. If a kidney transplant patient catches coronavirus, their risk of severe disease requiring hospital care is increased compared to somebody who's not a transplant patient. Their risk of death from coronavirus is also increased compared to someone who is not a transplant patient. It is important to protect yourself against coronavirus both before and after a kidney transplant. Vaccination is a key way to protect yourself against coronavirus. We recommend full vaccination against coronavirus to everyone on the kidney transplant register, including any additional doses offered to them. We recommend this because of the increased risks of coronavirus to kidney patients overall, as well as to kidney transplant patients. It is best to complete the course of vaccination against coronavirus before receiving a kidney transplant if this is possible. Once the patient is taking immunosuppression medication, they will not make a stronger response to any vaccine they have. It is important to have the protection offered by vaccination, but ideally, patients on the waiting list would have full vaccination against coronavirus before being transplanted, so that they have the strongest response possible to keep them protected when they do have a kidney transplant. However, if a person has not completed their vaccination against coronavirus, we will still offer them any transplant that could be suitable for them through all the usual systems. We also recommend that anyone living with someone immunosuppressed, such as a kidney transplant patient, also has full vaccination, including any additional doses offered to them, if they are eligible for it. This is often referred to as ring-fence vaccination and protects those people as well as the vulnerable kidney transplant patient. Unfortunately, we cannot reduce the risk of transmission of coronavirus within the hospital to zero. This means that even when someone comes in for a transplant, there is a small chance they might come into contact with coronavirus during their hospital stay, resulting in coronavirus infection. We make every effort to prevent this and will continue to do so, including taking on any new practices that we can do to reduce this risk as our understanding of coronavirus develops.
After your transplant, you'll need to take medicines to help stop your body from fighting off your new kidney. We call this rejection. And the medicines that we start for it are called anti-rejection or immunosuppression medicines. It is really important that you take these, so if you have any problems taking medicines before transplant, let us know now and we can help put things in place to give you and your kidney the best possible chance. Along with your immunosuppression tablets, we will also give you some medicines during theatre. We call these induction medicines. You will get one of two medicines called alemtuzumab or basiliximab. At Leeds, our first line medicine of choice would be alemtuzumab, because it allows us to use just one form of immunosuppression after transplant. If you can't have this, we will give you basiliximab, but you may have to take more immunosuppression. You will need to sign a consent form to say that you are happy to use alemtuzumab, and we will ask you to re-sign this every year when you come to clinic.
When you undergo a renal transplant, the transplant tissue itself is foreign tissue from a different individual with a different genetic background. This means that your own body will see this material as foreign. The natural reaction to foreign material in the body is similar to a vaccine. It generates an immune response and you start to make antibodies and other reactions against that tissue. If this was allowed to continue without any challenge, then of course you would reject the kidney. So we need to take drugs for the rest of your life while the transplant is working to ensure that you don't undergo episodes of rejection. This type of drug therapy is called immunosuppression, and it dampens down your own immune system so that you don't reject the renal transplant. The problem is that when you dampen down someone's immune system, you also render them more likely to develop infections and cancers. And these are the main side effects of immunosuppression. To combat this, we will give you what we call prophylactic drugs to try and prevent certain viral and bacterial infections. Also during that time, we'll see you very frequently in the clinic so that we can keep an eye on any infections that might develop. To counteract this, we would recommend that you continue to have vaccinations as appropriate through your GP, and this would include against things like influenza and pneumococcus. Vaccines can be given to transplant patients as long as they are killed vaccines. Another complication of immunosuppressive drugs are cardiovascular disease, and this includes things such as strokes and heart attacks. The risk of these sorts of conditions is much increased when you have renal failure, and one of the main advantages of undergoing a successful renal transplant is to reduce the risks of these events happening. It is important that you try and alter risk factors that may increase the risk of these sorts of diseases. So it's very important that after a transplant you stop smoking and that you keep both diabetes and blood pressure under good control. Unfortunately, one of the side effects of the immunosuppressant drugs is to increase the incidence of high blood pressure and also to increase cholesterol levels. So these are something that we will watch closely in the clinic, and it may be that you would need a drug like a statin to control the cholesterol and you might still need some blood pressure tablets. One of the main drugs that we use here in Leeds is tacrolimus, and these tablets are usually called Adaport, Advagraph or Prograph. Tacrolimus is a very important drug in the immunosuppressive regime and has been one of the main reasons that transplantation has progressed as far as it has over the last decade or so. The main side effects of tacrolimus are neurological, so patients often feel rather tremulous and can feel anxious or develop pins and needles in their arms and feet. However, these side effects can usually be controlled by reducing the blood level, or sometimes by taking a once daily preparation which avoids the peaks and troughs of levels. Tacrolimus can also cause problems with your blood sugar levels and even sometimes cause the development of diabetes, but usually we can control this again by running at lower levels. Other side effects of tacrolimus include occasional stomach upsets and diarrhea, and also thinning of hair, which can be problematic, but again is usually managed by reducing the levels in the blood. One of the good things about taking tacrolimus is that we usually reduce the dose after 3 months, and this allows the side effects to improve significantly. Another drug that we use frequently for immunosuppression is mycophenolate mofetil, or MMF as it's better known. The main side effects of MMF are to do with your guts, and in particular feeling sick or developing indigestion. Tummy aches are also quite common, and also diarrhea. However, these side effects can usually be managed either by using a slow release preparation or sometimes by using alternatives. Sometimes the MMF can also affect your white blood count and the platelet levels in the blood.
Due to the immunosuppression medication, after a transplant, people are at risk of a type of pneumonia. We therefore prescribe a daily preventative tablet to take during this time.
Although it sounds like we will be adding a lot of medicines to your regime after transplant, we will be able to stop some of those that you were taking beforehand for your renal condition. Things like phosphate binders, blood pressure medication, and iron management. We will of course discuss all of these changes with you when you come into hospital. This video will hopefully have answered most of your questions about the medicines that you might be prescribed after a transplant. When the time comes and you're in hospital, someone will sit down with you and go through these in more detail, including how to take them and any side effects you may experience.
So rejection is something that a lot of our patients fear, but happily, in the age of modern medicines, rejection is actually relatively uncommon after a standard kidney transplant. We give quite powerful medicines to the majority of our patients after a kidney transplant. Most of them can then simply take one medicine twice a day to prevent rejection. This is excellent and a significant reduction in the medication burden for patients after transplant. Rates of rejection are low with these medicines, lower than 6% in most cases over the first year after the transplant. There are patients who experience rejection nonetheless, and for this reason we have regular blood tests and clinic attendances, particularly in the first month after transplant. This allows us to watch carefully for signs of rejection in the blood tests before the patient would experience any symptoms. Whatever regime an individual is taking, it's important that they continue to take those medicines as directed by their transplant team to prevent rejection. Sometimes it's necessary to perform a biopsy of a kidney transplant. A biopsy means placing a needle into the transplant tissue to take a small amount out in order to look at that under the microscope to make a diagnosis and help the transplant patient. Biopsies are probably commonest in the early time after kidney transplant.
A number of infections are more common after transplantation, and these effects are largely brought about by the immunosuppressive drugs. In particular, certain viruses are more common after transplantation. One of the most common is something called cytomegalovirus, or CMV, as it is better known. CMV is actually very common in the community, and most people will have had a CMV infection by the time that they become an adult. When you undergo a transplant, your risk of developing CMV is much increased if you've never experienced it before and the donor has had the infection. If there is a risk of a CMV infection, then you will be given antiviral tablets, usually a drug called valganciclovir, to avoid picking up a CMV infection after the transplant. Fortunately, these drugs are very effective if taken regularly, and they only need to be continued for a maximum of 6 months. Another important virus after kidney transplantation is the BK virus. This virus is actually very common in normal people, and in most of us it lives within the kidney without causing any problems at all. The virus is kept in check by our immune system, but of course after transplantation, after taking immunosuppressive drugs, sometimes this allows the virus to escape from the kidney and into the bloodstream. Infections with this virus are actually reasonably rare. Only about 1 in 20 patients will suffer from an infection. However, we will remain very vigilant after the transplant looking for this virus. By reducing the dose of drugs, it allows your own body to fight back and the kidney function will stabilise or even improve. In a very small number of patients, the viral infection will progress and can cause failure of the graft, but this is an unusual occurrence.
There is an overall increase in long-term cancer risk associated with being a kidney transplant patient. This is largely a function of the medications that we give to prevent kidney transplant rejection. These medicines, called immunosuppressants, as well as stopping the kidney from rejecting, prevent the body from noticing when some cells are changing in what might become a precancerous state. The risk of any particular cancer varies and is not the same for all cancers. Of particular note, skin cancer risk is increased, and we are very keen to ensure that our patients are aware of the need for protection from the sun, whether they are in the UK or travelling abroad. We recommend using sun protection factor 50 or above, as well as a high UVB protection sun cream, whether the patient is in the UK or abroad, as well as ensuring that the skin remains covered when the person is in the sun. This is not a disorder that the vast majority of the public are at risk of, which is why it deserves specific mention in information about kidney transplantation. The rate of increase of other malignancies depends on a number of different factors. One of the important factors is whether the kidney transplant patient has previously had a cancer themselves prior to the transplant. There are specific types of cancer that can be driven by viruses which transplant patients are more at risk of than the general population. These cancers include post-transplant lymphoproliferative disorder, also called PTLD, which is driven by a virus in many cases called Epstein-Barr virus, or EBV. The symptoms of this kind of cancer are non-specific, and doctors looking after kidney transplant patients are vigilant to look for them. If the diagnosis of PTLD is made, I'm pleased to say there are effective treatments in the majority of cases. There is a balance between the treatment for cancer and a reduction in immunosuppression, whilst trying not to increase the risk of rejection too much for the patient. This is a difficult area that is usually managed in tandem with cancer doctors, oncologists.
One of our team will come and see you on the ward, and you will get used to our faces before you are discharged from hospital. If you are a Leeds patient, one of our team will continue to see you in the clinic outpatient setting. Otherwise, you will go back to your parent unit, be that York, Hull or Bradford. When you go home from the hospital, you will be returning to the clinic on a frequent basis. This is because we discharge you from hospital as soon as it is safe to do so, because home is a much better environment for you to recover in. The clinic appointments are long clinic appointments, and the main thing that we want to check is your weight, your blood pressure, that you are coping at home, that you are aware and taking the correct medication, and that we are doing a blood test.
Being a kidney transplant patient should provide an opportunity for an improvement in your quality of life. This is the experience of the vast majority of transplant patients, and one of the main reasons that we perform kidney transplants. To achieve this improvement in quality of life is a partnership between us as doctors and other healthcare professionals involved and the patient themselves. We rely on our patients to engage with us, to attend clinic when we need them to, and to have the blood tests we ask them to have, as well as taking the medication regimen that we've set out for them, in order for them to get the best out of their kidney transplant. This can, however, seem quite onerous, and are unlikely to come any less frequently than monthly in the whole of the first year after the transplant. This is because that's the time when patients experience most complications, such as rejection or infections associated with the suppression of their immune system to try to prevent rejection. Happily, after that first year, the leash is lengthened somewhat, and most of our patients are on 3 to 4 monthly follow-up if things are stable.
Shortly after your kidney transplant, you will see one of the renal dietitians on the ward. This is to make sure that you're eating and drinking okay after your operation, although we do realise that most people will eat better once they are home. It's important to eat well after you've had a transplant, as it can help the wound to heal. It's also important to make sure you're drinking enough fluid so that the kidney can work as well as it can. Some people find that they feel quite full after drinking enough fluid but don't feel hungry for food. The renal dietitian can advise you on how to manage this until your appetite improves. After having a kidney transplant, you need to take immunosuppressant medicines, which means you are more at risk of some infections, including food poisoning. It is important to practice good food hygiene, which means cooking food thoroughly, and for example, making sure that burgers are cooked through and there is no pink meat, and that you avoid eating rice that has been reheated. The renal dietitian can give you more information about food safety practices. If you have been following a low potassium diet, after your kidney transplant, this can usually be stopped. If you've been following a low phosphate diet, this can usually be stopped after a transplant. A few weeks after having a kidney transplant, most people find that they have a good appetite and are enjoying their food. Being active and eating a healthy diet can now help you to keep well for the future. It is important that any diet for other conditions such as diabetes is still followed. This can mean that the amount of information you have about diet can be quite overwhelming. So please ask to speak to one of the renal dietitians, as they can make it more manageable for you.
Returning to work very much depends on the type of occupation that you have. If you're able to resume light duties, then we would encourage you to return to work if you feel well enough after about 6 weeks. If your job is more manual, then we would recommend up to 12 weeks time off work. We don't recommend that anybody drives within 6 weeks of having their transplant surgery, as this may impede your ability to perform the emergency stop. The type of benefits you're entitled to following your transplant can depend on many things, but can be subject to change, and we can refer you to the social worker team for advice as part of your transplant assessment.
What we do say is don't sit at home and worry. If you have any concerns or worries, then we would rather you ring, even if you don't think it is anything, because the sooner we know that you have a problem at home, the sooner that we can do something about it. Something that we get asked very frequently when somebody is transplanted is, when can I go on holiday? That is a really positive thing, and it's something that we love to hear. But we do have some words of advice on that from the word go. Holidaying within the UK is great, and you will be guided from that from your outpatients clinic, remembering that you are coming really frequently at first to clinic. So ask the doctors that you are seeing and get the okay before you go ahead and book something. Going abroad is slightly more difficult, so you have to remember that you've had a big operation and there are some do's and don'ts that we need you to remember. Again, just follow advice and ask the doctors in the clinic setting before you book anywhere. We usually advise travelling to Europe, certainly within 9 months to a year. Make sure that you have adequate travel insurance, and we will give you top travelling tips before you actually travel. You will need a letter to cover you, and we need to talk to you about medications, correct diet and fluids, etc. within a foreign country. Travelling outside Europe, again, we would advise at least 18 months. Another question that we get asked quite frequently is about how soon can I have a baby? And again, that's great. We love the positivity with these questions, but we do need you to be guided by us. There are some medications that you can't take when you are planning a family. So all we ask you to do is to speak to either a member of our team or one of the doctors in the clinic setting prior to conception.
Happily, a kidney transplant is seen as a treatment for fertility, and a woman's chance of becoming pregnant and carrying a baby to term really increases following a transplant. In some cases, a menstrual cycle restarts when it previously had stopped. We therefore advise contraception after a transplant, which may not have been previously required.
We strongly encourage our recipients to write to the family of their donor to express your thanks for the gift received. Letters and cards from the recipient and family members are welcomed by the donor's family and will often be something that they treasure and want to share with their family and friends. It can be a difficult letter to write, and your transplant coordinators will be able to help you with sample letters, and it will take time to help you put down the words that you want to say to the family of your donor. If you use social media, we would ask you to be mindful about the type of information that you share. We ask you not to share details about the date of your transplant and any donor details that you may be aware of. This is to protect yours and your donor's anonymity.
For the majority of patients undergoing kidney transplant, there is an improvement in life expectancy. Kidney transplantation, done in younger patients particularly, can be expected to extend their life substantially. The average life of a live donor kidney transplant is now in excess of 20 years, and for many of the deceased donor transplants, the average life would be more than 15 years. Instead of spending this time on dialysis, which has medical complications of its own in the long term, patients have a more natural system of kidney function through the transplant, despite the immunosuppression that they have to take, which seems to assist their natural biology in keeping them alive. For people who are over 80 years of age, it is unlikely that kidney transplantation will lengthen their life significantly. Of course, there is a substantial quality of life improvement that may be of benefit to them.
Hi, my name is Aki Suryavansi. I'm a donor to my son Akash Suryavansi. If you are thinking of being a donor, come forward, speak to your family, speak to the renal team. You can't give anything more than an organ as a gift of life. His life just changed completely. It was like a different person was there. So the gift of life, you can't beat it.